Welcome to the deep dive. Today, we're taking on a slightly different kind of mission for you. It's a rapid review. We've got this fantastic source document. It's basically like a lightning fast Q&A, really designed to distill that high yield info on genetic and metabolic disorders. Think of it as, your shortcut to getting incredibly well informed on some really complex topics without getting too bogged down. Our goal is to guide you through this material, help you grasp the core concepts, the key presentations, and management strategies quickly and, well, clearly. This deep dive is structured as a dynamic conversation, almost like you're sitting in on a session with us, yeah? As we kind of unpack this material, we're going to dive right into the heart of it, covering each condition with precision and clarity. Okay, let's unpack this with our first topic, Lesch-Nyhan syndrome. It really highlights the profound impact of just a single enzyme deficiency. So welcome back to our rapid review. Today we're diving into a series of high-yield genetic and metabolic disorders. Expert speaker, let's start with Lesch-Nyhan syndrome. What's happening at the molecular level?
All right, Lesch-Nyhan syndrome results from a complete deficiency of the enzyme hypoxanthine guanine phosphorylation, or HGPRT. This enzyme is critical in the purine salvage pathway, recycling purines back into nucleotides. So, building blocks for DNA, RNA. Without it, purines must be made from scratch via the de novo pathway, which generates excessive uric acid as a byproduct.
Okay, so that's the biochemical core, but how does it present clinically?
Infants often appear normal at birth, but as they grow, they develop hyperuricemia, leading to gouty arthritis and uric acid kidney stones. Neurologically, you see dystonia, chorioiditis, spasticity, and classically self-mutilation behaviors such as biting the lips or fingers. That's the really striking part. Diagnosis is confirmed by enzyme assay or genetic testing for HGPRT1 mutations.
Yeah, that self-mutilation symptom is just incredibly striking. It really underscores those deep, often unexpected links between biochemistry and behavior, and how is it managed?
Well, as for why it happens, it's tied into the neurological dysfunction from the purine imbalance, though the exact pathway is still being researched. But management, well, there's no cure. Allopurinol or febuxostat can reduce uric acid levels. Supportive care addresses neurological issues and prevents self-injury, often requiring behavioral strategies and protective gear.
A challenging condition. Okay, moving from enzyme issues to blood production. Next is beta-thalassemia. What's the underlying defect?
Okay, beta-thalassemia. Mutations at splice sites or promoter sequences in the beta-globin gene impair mRNA processing, leaving introns in the transcript. Basically, junk DNA stays in. This reduces or eliminates beta-globin chain production, creating an imbalance where excess alpha chains precipitate and damage developing red blood cells.
Got it. What does that mean clinically?
Severe forms present in early childhood with profound anemia, growth delay, hepatosplenomegaly, and bone changes like crew-cut skull from marrow expansion. The body's really trying to compensate. Lab work shows microcytic hyperchromic anemia, small pale red cells. Hemoglobin electrophoresis reveals reduced HbA with increased HbF and HbA.
Okay, a clear picture there. And in terms of treatment?
Lifelong transfusions are often needed, which can cause iron overload. Sodulation therapy with agents like deferoxamine or defercerox is essential. Got to get that extra iron out. In select cases, stem cell transplant is curative. Genetic counseling is important for affected families.
Right. So let's shift gears now, thinking about cancer risk. Let's move on to Lynch syndrome.
Okay, Lynch. This is caused by germline mutations in mismatch repair genes, MLH1, MSH2, MSH6, PMS2, leading to microsatellite instability. So the DNA spell checker is broken. The DNA repair failure allows accumulation of replication errors, especially in repetitive sequences, promoting carcinogenesis. Errors build up, cancer risk goes up.
Which cancers are most concerning?
Colorectal cancer, particularly right-sided and early onset, is most common. There's also elevated risk for endometrial, ovarian, gastric, small bowel, and urinary tract cancers. So, quite a range. Diagnosis involves tumor testing for microsatellite instability or MMR protein loss, followed by germline genetic testing.
And management?
Regular colonoscopy starting in early adulthood, endometrial screening, and in some high-risk cases, prophylactic surgeries. Surveillance is key. Family members should be offered testing. It's inherited, after all.
Okay, that makes sense. Proactive screening is vital there. Now, I-cell disease is next. What's happening at the cellular level?
Right, I-cell. Also called mucolipidosis type 2, it's due to a defect in N-acylglucosamine-1 phosphotransferase in the Golgi apparatus. It's a mouthful, I know. This enzyme normally tags lysosomal enzymes with mannose 6-phosphate, so they're sent to lysosomes. Think of it like a postal code for enzymes. Without the tag, enzymes are secreted outside the cell, leaving lysosomes full of undegraded material. The cell's recycling bins get clogged.
How does it present if the recycling isn't working?
Infants develop coarse facial features, gingival hyperplasia, restricted joint movement, developmental delay, and sometimes corneal clouding. Labs show elevated lysosomal enzymes in plasma. They're ending up in the wrong place. Biopsy reveals fibroblasts with inclusion bodies, hence the name ICEL.
Any effective therapy?
Unfortunately, management is supportive physical therapy, surgical correction of orthopedic issues, and symptomatic care. No direct cure yet.
Tough one. Okay, let's shift focus to bones now. Let's discuss osteogenesis imperfecta.
Right, OI or brittle bone disease. This is usually due to mutations in COL1A1 or COL1A2, leading to defective type I collagen synthesis. Collagen is like the rebar in concrete for bones. Without normal triple helix formation, connective tissues, especially bone, are fragile.
The classic signs. What should you look for?
Recurrent fractures with minimal trauma is the big one. Blue sclera from thin connective tissue revealing underlying veins, hearing loss from ossical abnormalities, and dental defects like opalescent teeth. X-rays often show fractures of various healing stages.
Okay, very distinctive. And treatment?
Bisphosphonates to increase bone mass, physical therapy, and orthopedic surgery for deformity correction or fracture prevention. Genetic counseling is also important.
Makes sense. Now, on to something involving a trace mineral. Now, Menkes disease.
Caused by ATP7A mutation, an X-linked defect in a copper-transporting ATPase. So it's about getting copper where it needs to go.
Oh.
This blocks copper absorption and distribution, leading to deficient activity of copper-dependent enzymes, including lysyl oxidase, which is vital for collagen cross-linking. Copper is needed for strong collagen.
So the connective tissue suffers, like OI, but a different mechanism.
Exactly. Connective tissue takes a hit. Infants present with hypotonia, seizures, developmental delay, and characteristic kinky, depigmented hair. The hair is quite unique. Romian bones may be seen on skull X-ray. Labs reveal low serum copper and ceruloplasmin.
How's it handled?
Early parenteral copper supplementation can improve outcomes if started before significant neurodegeneration, but prognosis remains poor. Timing is critical. Supportive neurologic and nutritional care is essential.
Okay. And wrapping up this section, let's look at another connective tissue disorder. Finally for today, Marfan syndrome.
Marfan, an autosomal dominant condition caused by FBN1 mutation on chromosome 15, leading to defective fibrillin 1. Fibrillin is key for elastic fibers. This weakens connective tissue and increases TGF activity, affecting elastic fiber stability.
Key physical findings. What are the telltale signs?
Tall stature, long limbs and fingers, arachnodactyly, hypermobile joints, lens dislocation, upward and temporal, pectus deformities, and most importantly, aortic root dilation, predisposing to dissection or rupture. The heart issue is the big concern.
Absolutely. And preventive strategies.
Regular echocardiographic monitoring, beta blockers or ARBs to reduce aortic stress, surgical repair of the aorta when indicated, and lifestyle modifications to avoid strenuous activity. Ophthalmologic follow-up is also necessary. Perfect.
All right, now moving into the second part of our rapid review. Expert speaker, let's continue with Prader-Willi syndrome. What's the genetic basis here?
Okay. Prader-Willi. Prader-Willi syndrome occurs when paternal expression of genes in the 15q11q13 region is lost. So it matters which parent the gene comes from. This most often results from a deletion on the paternal chromosome, but it can also occur when both chromosome 15 copies come from the mother, a phenomenon called maternal uniparental dysplasimy, or through imprinting defects where the paternal genes are silenced. Different ways to lose that paternal input.
That's fascinating, the imprinting aspect. How does that translate clinically?
Infants often present with severe hypotonia and poor feeding, but later in childhood they develop hyperphagia, leading to rapid onset obesity. It's a real switch. Other features include intellectual disability, short stature, hypogonadism, and characteristic facial features like almond-shaped eyes and a narrow bifrontal diameter.
That change from poor feeding to hyperphagia is so distinct. What's the management approach?
Strict supervision of diet and caloric intake is critical. Absolutely vital. Growth hormone therapy can improve stature and body composition. Developmental support, physical activity, and hormone replacement for hypogonadism are often needed. It's multifaceted.
Right, and sticking with that same chromosome region. Next up, Angelman syndrome.
Yes, the counterpart. Angelman syndrome is the counterpart to Prader-Willi, but involves loss of maternal gene expression in the same chromosomal region, specifically the UBE3A gene. The paternal copy is normally silenced in neurons, so without the maternal one, there's no functional gene expression in those cells. So here, the maternal copy is crucial.
And the presentation, how does it look different from Prader-Willi?
Children often have severe developmental delay, ataxia, seizures, frequent inappropriate laughter, and a happy, excitable demeanor, often called the happy puppet syndrome, though we try to avoid that term now. They may also have microcephaly and characteristic jerky movements.
How is it managed?
Treatment is supportive antiepileptics for seizures, physical and occupational therapy for motor coordination, and speech therapy for communication deficits. Early intervention helps maximize developmental outcomes.
Okay. Now let's move to a really common one. Now, cystic fibrosis. This one's quite common.
Indeed. It's caused by mutations in the CFTR gene on chromosome 7, most often the F508 deletion. This mutation impairs an ATP-gated chloride channel, reducing chloride secretion in the lungs and GI tract and decreasing chloride reabsorption in sweat glands. It messes with salt and water movement. The result is thick, viscous secretions that obstruct ducts and airways. That's the core problem.
Makes sense how that one channel causes such widespread issues. What are the hallmark features?
Chronic lung infections, especially with Staphylococcus aureus in children and Pseudomonas aeruginosa in adolescents and adults. Big problem. Pancreatic insufficiency causes statorrhea and failure to thrive, and newborns can present with meconium ileus. Gut issues are prominent too. Males often have infertility from congenital bilateral absence of the vas deferens. The salty skin on exam is classic due to that sweat gland issue.
So much to manage there. How do we manage it?
Airway clearance therapy, inhaled bronchodilators, and aggressive antibiotic use for infections. That's for the lungs. Pancreatic enzyme replacement and fat-soluble vitamin supplementation are essential for the digestion. CFTR modulator drugs like avacaftor or lumacaftor-revacaftor can improve chloride channel function in eligible mutations. These newer drugs are game changers for some.
It's great to see those targeted therapies. All right, next, Duchenne muscular dystrophy is next.
Duchenne. This is an X-linked recessive condition caused by frameshift mutations in the dystrophin gene, resulting in absent or non-functional dystrophin protein. Dystrophin stabilizes the sarcolemma during muscle contraction. Without it, muscle fibers degenerate over time. The muscle structure just isn't stable.
What does that look like clinically?
Boys typically present between ages 2 to 5 with progressive proximal muscle weakness, delayed motor milestones, and calf pseudohypertrophy. Those calves look big, but it's not muscle. The Gower sign using hands to walk up the legs to stand is a classic finding. Cardiomyopathy is a major cause of morbidity. Creatine kinase levels are markedly elevated early in the disease. Muscle breakdown marker.
What can be done?
Corticosteroids can slow disease progression by some time. Physical therapy maintains mobility, and cardiac monitoring with treatment for cardiomyopathy is vital. Heart health is critical. Experimental gene therapy is under investigation. That's the hope for the future.
Let's hope that pans out. Okay, one more in this group. Let's go over myotonic dystrophy.
Right, the most common adult onset form. This is the most common adult onset muscular dystrophy and is autosomal dominant. It's caused by a CTG trinucleotide repeat expansion in the DMPK gene, which leads to abnormal expression of myotonin protein kinase, affecting muscle relaxation. It's a repeat expansion problem.
How does it present? The key is in the name, right?
The hallmark is myotonia-delayed muscle relaxation after contraction. Exactly. Patients may describe difficulty releasing a handshake or letting go of a doorknob. Classic example. Other features include muscle wasting, frontal balding, cataracts, testicular atrophy, and cardiac conduction defects. It's multisystemic.
In management.
Symptomatic treatment for myotonia, such as mexolentil, can help. Cardiac evaluation with regular ECGs is essential due to the risk of arrhythmia, and pacemaker placement may be required. Again, heart monitoring is crucial. Ophthalmologic exams for cataracts and physical therapy for muscle maintenance are also important.
Excellent. Okay, starting our final section now, focusing on metabolic and nutritional issues. Expert speaker, let's start this section with Fragile X syndrome.
Fragile X. Fragile X is the most common inherited cause of intellectual disability. Very significant. It's an X-linked dominant condition due to a CGG trinucleotide repeat expansion in the FMR1 gene, another repeat expansion disorder. The expansion causes hypermethylation of the gene, silencing it and reducing production of the FMRP protein, which is essential for normal synaptic development. Turns the gene off.
What are the hallmark features?
Males are more severely affected. Findings include intellectual disability, macroorchidism after puberty, a long, narrow face, large overted ears, joint laxity, and sometimes behavioral features like hyperactivity or autism spectrum traits.
And management.
There's no cure management. Management is supportive, focusing on early intervention, speech and occupational therapy, and pharmacologic treatment for associated behavioral issues such as ADHD or anxiety. Support is key.
Okay, now for something seemingly simpler, but with big effects. Now on to Bateau spots and vitamin A deficiency.
Yes, vitamin A. Vitamin A deficiency impairs the differentiation of epithelial cells, leading to squamous metaplasia. Cells change shape, basically. In the eye, this manifests as keratinized conjunctival plaques called Bateau spots. You can actually see them.
What else should we look for besides the spots?
Early signs include night blindness. That's often the first clue. With progression, xerophthalmia, corneal dryness, and eventually keratomalacia can occur, risking blindness. It can get very serious.
Treatment.
Vitamin A supplementation, orally or intramuscularly, depending on severity, and dietary counseling to prevent recurrence. Thankfully, treatable if caught.
Critical scenario time. Wernicke encephalopathy in an alcoholic patient given glucose. What's the mechanism? Why is this dangerous?
Super important. Thiamine, vitamin B, is a cofactor in carbohydrate metabolism. In deficiency, giving glucose accelerates depletion, impairing ATP production and precipitating or worsening Wernicke encephalopathy. Giving sugar without thiamine makes the brain's energy crisis worse.
The clinical picture.
The classic triad is ophthalmoplegia, ataxia, and confusion. Eye movement problems, coordination issues, confusion. In chronic cases, Korsakoff syndrome with memory loss and confabulation may follow. Long-term memory damage.
Key step in management.
Always give thiamine before or with glucose in at-risk patients. Thiamine first, always.
Got it.
Yeah.
Another deficiency link. How about pellagra in malignant carcinoid syndrome?
Interesting connection here. Carcinoid tumors can divert tryptophan towards serotonin production, reducing availability for niacin vitamin B. Synthesis. The tumor steals the building blocks for niacin. Niacin deficiency causes pellagra dermatitis, diarrhea, and dementia. The classic 3Ds.
And the approach.
Treat the tumor, address the diarrhea, and supplement with niacin. Treat the cause and replace the vitamin.
All right. Clarifying another nutritional state. Kwashiorkor is next.
Kwashiorkor. Kwashiorkor results from protein malnutrition with adequate calories. Enough calories, but not enough protein. The low oncotic pressure from hypoalbuminemia leads to edema, while impaired apolipoprotein synthesis causes fatty liver. Low protein causes fluid shifts and liver issues.
Hallmark signs.
Edematous appearance, skin lesions, hair depigmentation, and a protuberant abdomen. Swelling is key.
Management.
Gradual nutritional rehabilitation with adequate protein and monitoring for refeeding complications. Got to go slow and careful.
Okay. Another metabolic issue in alcoholism, lactic acidosis and fasting hypoglycemia in alcoholism. What's the mechanism?
It's about the NADH-NAD plus ratio. Excess ethanol metabolism raises the NADH-NAD-Q ratio, shifting pyruvate to lactate and oxaloacetate to malodate. Metabolism gets skewed. This impairs gluconeogenesis and increases lactic acid levels. Can't make new sugar and lactate builds up.
And management.
Correct hypoglycemia with glucose, address hydration and electrolyte disturbances, and treat underlying alcohol use disorder. Fix the sugar, fluids, and the root cause.
Now, a dangerous toxicity effect. Aspirin-induced hyperthermia. What's happening there?
Aspirin overdose. Salicylates increase mitochondrial membrane permeability, disrupting the proton gradient and uncoupling oxidative phosphorylation. It basically makes the mitochondria leaky and inefficient. This causes excess oxygen consumption and heat production, burning fuel like crazy, but generating heat instead of useful energy.
Clinical implications.
Presence is hyperthermia and metabolic acidosis, high fever, acid buildup. Management includes cooling, supportive care, and alkalinization of urine to enhance salicylate excretion. Cool them down, support them, help them pee out the aspirin.
Okay, almost there. Hereditary fructose intolerance.
Due to aldolase B deficiency. Specific enzyme missing. Fructose-1 phosphate accumulates, depleting phosphate stores and inhibiting glycogenolysis and gluconeogenesis. Buildup poisons other energy pathways.
Presentation. What happens when they eat fructose?
After fructose ingestion, severe hypoglycemia, jaundice, vomiting, hepatomegaly. Very sick, very fast. Eliminate fructose, sucrose, and sorbitol from the diet. Strict avoidance is key.
And our final one for this review. Finally, classic galactosemia.
Galactosemia. Caused by galactose-1 phosphate uridyltransferase deficiency, another enzyme block. Galactose-1 phosphate accumulates, and toxic substances like galactitol build up, particularly in the lens, causing cataracts. Similar buildup mechanism, different sugar.
How does it present, especially in babies?
Newborns develop jaundice, Hepatomegaly, vomiting, poor feeding, and risk of E. coli sepsis can be very severe early on. Cataracts may appear early.
And management?
Remove galactose and lactose from the diet immediately to prevent complications. Immediate dietary change is crucial.
Wow. Okay. That was an incredible journey, really, through so many intricate genetic and metabolic conditions, done in such a focused way. You've just received, well, a rapid-fire download of essential knowledge, what's happening molecularly, how these things present, how they're managed. And here's where it gets really interesting thinking about the connections.
Yeah, if we step back and look at the bigger picture,
Yeah.
what really stands out, I think, is the profound and sometimes really unexpected impact that just a single gene change or one missing enzyme can have. It just ripples through the whole system from, like we saw, a missing protein causing something as specific as self-mutilation or a common sugar leading to multi-organ failure. It really highlights the delicate balance of our biochemistry, doesn't it? And, well, the ongoing science trying to understand and hopefully intervene.
Absolutely. So, what does this all mean for you listening? Perhaps it's a fresh appreciation for just how complex and interconnected our biology is, or maybe it sparks a new curiosity. How do these discoveries actually translate into medical advancement, into the daily lives of people affected? What fascinating detail from today's deep dive will you be mulling over? There's certainly a lot packed in there. Thank you for joining us on this deep dive. Until next time, keep exploring, keep questioning, and keep learning.